All right, guys, we're gonna go ahead and continue with this. We will learn the three ways that the vessels constrict or dilate, and it's because of. Let me go ahead and put back that slide. Let's start with the local control. Okay, so here we are. Locally, it means what's happening right at the area of the tissue. There's auto-regulation. This is the ability of the vessel to react to what's happening in the area that's it's belonging to. For example, if the area is inadequately perfused for some reason, there that could happen in diabetes. That could happen when there's constriction of the vessel. Now, when that happens, the waste will accumulate, and with that, the tissue, the area itself, will make the vessel dilate because it feels like it needs to get that waste out. Acidity will hasten that reaction. Then the vessel will feel that it needs to perfuse the area and therefore will dilate. Once dilated, the area will get enough perfusion. Blood flowing in the area will deliver oxygen and remove metabolites. When the waste is removed, the vessel will automatically constrict again. This is like a defense mechanism by the body. Another thing that would make the vessels dilate is if there's a release of histamine, bradykinin, prostaglandin, this all causes vasodilation. Histamine is a good example is if there was an insect bite, histamine will be released. Bradykinin, which uh, enhances pain sensation, will also dilate the vessel. And so all this is a reaction because of vasoactive chemicals in the area. Endothelial cells will secrete prostacyclin, which favors dilation, and also nitric oxide will also favor dilation. Right. And by way of that, you actually enhance clearing the area of any toxin, of any allergen, and therefore the area gets to be thoroughly processed by immune cells and therefore be able to sort of clean it. Whatever allergen was taken in will be taken to the kidney and then filtered out. So it's almost again a defensive mechanism by the body. And this is locally happening. Reactive hyperemia is when, for some reason, the blood supply is cut off and the flow will increase above normal. Let's say you're in a position like in a crouching position, or when you maintain that position for a long time and you feel your extremity is numb because the blood flow has been tight for a few minutes, right? Sitting for a long time sometimes makes you feel like your thighs are feeling numb, right? But when you stand up and blood supply is restored, you will feel that hyperemia flow happening. Of course, the flow will be increased. Sometimes it feels like pins on your toes, right? That's reactive hyperemia. Angiogenesis is when there's new blood vessel growing. This could be the uterus growing. This could be an injury trying to have new blood vessels perfuse areas were injured and now healing. This could also be in muscles that are stimulated and they're now hypertrophied. This could also, in the negative side of it, be malignant tumors that are now wanting to get more nutrition and therefore will enhance new growth. All right. Let's go to nervous or neural control. Neural control can be seen when baroreflexes, chemoreflexes, and medullary ischemic reflexes work and start functioning. The autonomic nervous system and the central nervous system is involved in these reflexes. The vasomotor center, which is in the medulla, will exert sympathetic control over blood vessels. By doing this, whenever it's a fight or flight situation, then it will concentrate flow of blood to the more vital organs, the brain, the heart, the lungs, right? Muscles that need to um, more blood flow. It will constrict vessels where we don't need much blood flow, like your urinary system maybe. Well, there still will be flow, but to the minimum. We don't want a potty in the middle of a fight or flight situation. Skin would be to the minimum because we don't need perfusion that much at this time. We need perfusion, but not that it would be going all the way to the smallest vessel of the capillary. This will continue on until the situation has stabilized and we would have shifted back to parasympathetic situations. Again, baroreflex is more for pressure, huh? Increase in blood pressure picked up by carotid sinuses. Glossopharyngeal nerve sends a signal to the brainstem, and there will be inhibition of the sympathetic, cardiac, and vasomotor neurons. Baroreflex also has a short-term regulation, so as soon as the change in posture is achieved, then it will go back to the normal pressure. Here's a flow diagram. When the blood pressure is high, the arteries are stretched and will trigger the baroreceptors to increase firing rate. It will stimulate the cardioinhibitory. We remember our goal is to slow down or reduce blood pressure. So the cardioinhibitory will work and increase vagal tone, reducing heart rate, reducing blood pressure. The vasomotor, who is more for increasing heart rate, is inhibited, and therefore the sympathetic tone is reduced and the vasodilation will happen. Therefore, blood pressure will decrease down. This is also a defensive mechanism of the body. Chemoreflex, like we said, is involved in the oxygen, carbon dioxide levels, acidity, alkalinity, and will increase or decrease uh, contraction of the heart in order to hasten disposal of this acidity or alkalinity. Secondary role of this, as that's for the primary role. The secondary role is in changing the dilation or constriction. Well, when the chemoreceptors are triggered, this will increase vasoconstriction, increasing blood pressure, increasing lung perfusion, and gas exchange. This will also stimulate breathing. Hypoxemia is low oxygen, while hypercapnia is increase in carbon dioxide, which is a must for the body to get rid of it. The medulla oblongata is also uh, geared to producing an ischemic reflex. So when there is low perfusion in the brain, especially in the medullary brainstem area, it will start corrective reflexes. The cardiac and vasomotor centers will send sympathetic signals, increasing heart rate and contraction force. Therefore, it will ensure that blood flow and perfusion is happening or will not be reduced in the medulla oblongata and in the brain. Other limbic system responses like stress, anger, can also increase blood pressure. Let's go to hormones. Hormones can also alter blood pressure. For example, angiotensin 2 triggers when you have low pressure. And so it will do all in its power to increase blood pressure. It could increase fluid intake. It can definitely be a potent vasoconstrictor. And it will also decrease sodium output and keep sodium, because when you keep sodium, you also keep water. Water is attracted to where sodium is. Another hormone, atrial natriuretic peptide, ANP. Whenever the heart is experiencing a lot of pressure, it will think that we need to reduce the pressure. So therefore, it will release ANP, atrial natriuretic peptide. What it will do is it will go to the kidney and reduce the absorption of sodium. It will let sodium be wasted because when sodium goes out of the urinary system, water will follow. And when water will follow, we reduce the volume and pressure, exactly what the heart is wanting to do. So again, this is one of the few instances when we actually want to lose pressure. And that's because there's too much pressure, too much work for the heart. ADH, antidiuretic hormone, is triggered when the brain, especially the hypothalamus, senses the lack of water, or the osmoreceptors are triggered, showing that the blood is concentrated. It will work with the urinary system and open up aquaporin so we can bring back water in. And bringing back water in clears the osmotic need of the blood. Epinephrine and norepinephrine in most vessels bind to alpha adrenergic receptors, resulting in vasoconstriction, especially when fight or flight ensues. Some other organs that don't need attention at that time may be just maintained in perfusion, but will be slightly constricted, so blood goes back to the vital organs that need more blood. So, with that said, cardiac muscles, beta adrenergic receptors will dilate the vessels so your cardiac muscles can be well perfused. These vasoreflexes have a good general control of blood pressure and also routes the blood from one body to the other. These are reflexes that is maintained in order to make the body survive. Increasing blood pressure requires medullary vasomotor center or widespread circulation of a hormone, especially when you have a inciting situation like bleeding or dehydration. This can be sympathetically driven, or a metabolite can accumulate, leading to a tissue and its local circulation being in the flow. If a specific artery constricts, the pressure downstream drops. The pressure upstream rises, which makes sense, and a reflexive vasoaction will be made by the body to address this. So in exercise, blood flow to the lungs, heart, and muscles will dilate, like we said. But in exercising, we probably don't want to urinate a lot, so there'll be vasoconstriction in the kidneys and digestive system. We probably don't want to make fecal procedures or defecate at that time. So less flow would be observed in those areas. Dozing in armchair after a big meal is like relaxing. You are now in a parasympathetic mode. Vasoconstriction in the lower limb raises blood pressure, redirecting blood to intestinal arteries, which then helps to supply oxygenated blood to the working intestines. After which, vasodilation can also happen on the venous side in order to redirect digested and absorbed nutrients to the portal circulation of the liver. So that's what you see here. Huh? Again, in a parasympathetic mode, we are directed on the blood is directed on the digestive and urinary system and other systems that were not used in the sympathetic mode. In the sympathetic mode, blood is directed more to the vital organs in order to survive or excel in that procedure or in the activity. Here's the blood distribution uh, at rest, where you see muscular don't have the bigger pie, but when you have an exercise activity going on, you can see a lot of blood flow involved in the muscular system. In capillary exchanges, most important situation here is that blood perfusion in the capillaries are working well. Capillary exchange has a two-way movement of fluid. As fluid moves, nutrients, oxygen, glucose Minerals, antibodies, even hormones that need to be delivered to the tissue of this organ is being delivered at this time. Right? Any waste, any carbon dioxide, ammonia will be picked up at the venous end and delivered to the kidneys or the respiratory system for disposal. We have endothelial cell cytoplasm, which these chemicals pass by. There'll be intercellular clefts as well and filtration pores. Mechanism of diffusion, where you have concentration of high areas going down to areas of lesser concentration will happen. Transcytosis, passing of elements from cell to cell. Filtration, where the pressure of the heart uh, on the blood flow will help in cleaning up the blood by filtering it, and also reabsorption, which also follows diffusion processes. Diffusion is the most important mechanism in this level, in the capillary level. Glucose, oxygen follow the law of diffusion or the method of diffusion. Carbon dioxide and other waste as well. The solute can permeate the plasma membrane of the endothelial cells, then we can have diffusion. If the passages are large enough to pass through, then filtration can happen as well. Lipid-soluble substances pass through plasma membranes easy. Water solubles usually do not. They need filtration pores. Uh, all these, especially in the kidneys, will experience filtration, but it should be the large proteins and particles in the blood that don't need to be pushed out should stay in, like your red blood cells. They should stay in the circulation. Only filtrate should be allowed to go through, especially in the kidney when it's passing through the glomerulus. We mentioned this a while ago. And here's a red blood cell inside the capillary, and you'll see filtration pores which let small elements, waste, to be pushed out due to the pressure. Consider an artery in the capillary. There will be juices that tend to push the items out, like your blood hydrostatic pressure. This is high on the arterial end and low on the venous end. There's colloid osmotic pressure that draws the fluid in instead of pushing it out. This is against the blood hydrostatic pressure. The net colloid osmotic pressure would be blood colloid osmotic pressure minus a tissue colloid osmotic pressure. The capillaries reabsorb about 85% of the fluid as they near the venous end, but 15% usually is left, especially in areas further from the venous end. Let's look at that in a picture right here. So this would be the capillary level. This is shown with arterial side connecting the venous side through this capillary vessel. And again, this is drawn like this so you can better visualize it. But imagine this happening to many vessels all around the capillary level. So numerically, the forces at the arterial end favor filtering out. Water, glucose, elements that need to be delivered to the tissues here will go out. This is because the pressure involved in pushing out dominates rather than keeping them inside. You can see here hydrostatic, blood hydrostatic pressure, interstitial hydrostatic pressure favor pushing out the filtrates, while the proteins inside the blood vessels, colloid osmotic pressure trying to push it back is less than the pressure pushing it out. So elements end up being pushed out. And this is good because the tissue needs them, right? So oxygen, um, nutrients, sometimes hormones are pushed out. Huh? But on the venous end, the hydrostatic pressure is not as strong. In fact, that's the one that lessens the power here. You now only have 13 millimeter mercury of power pushing out elements from the blood vessel, but now forces that are trying to keep it in, osmotic pressure from pulling the water in, and also oncotic pressure from the tissue fluid favors water to return at this venous end. So about 85% of it return at the venous end. The areas where you are further away and this is not being osmotically driven or pulled by the proteins here in the blood, the area further away is about 15%. That 15% will later be picked up by the lymphatic system. The lymphatic system ultimately joins the venous system at the subclavian veins. So you more or less pick up all the fluid that you delivered at the arterial end. This is good, especially when there's no fluid left behind here. Fluid left behind here will end up in edema. That happens also when the fluid is not able to be pulled back in. For example, you have low protein or there's a problem with diffusion. Sometimes fluid here will also accumulate when there's low hydrostatic pressure coming from the heart. If the fluid is low here and not able to push this blood completely right away, then it will stay in the blood vessel and this will enhance diffusion of the blood, osmotic pool of the water. Where there's more water in the blood vessel, there's less in the tissue. This will drive the water to go out. And when that happens, you end up with edema. It's not coming back that much. Okay? So water will make, low pressure will make water osmotically go to the tissue level. And it will stay there and become edema. All right, we mentioned this. Capillaries reabsorb most of the fluid. Kidney capillaries in the glomeruli do not reabsorb. They actually help filter out. Alveolar capillaries in the lung absorb completely to keep fluid out of the air spaces, so you don't have problems with perfusion and ventilation. Collapse in resting capillary activity varies from moment to moment. Collapse in resting tissue, reabsorption predominates since blood pressure is low. Metabolically active tissue has increase in capillary flow and pressure. Edema, like we said, can happen, and when this happens, it can be because of increased capillary filtration, especially in kidney failure and histamine release. Old age also affects capillary filtration. Poor venous return also is a big factor when there is increased capillary filtration. If there's reduced capillary absorption, like you have low protein or there's low liver problems, that's why you have low protein. Dietary low intake of protein can result in reduced capillary reabsorption or absorption of fluid back. When the lymphatic system is blocked or obstructed, then it cannot bring back the fluid that it picked up, the 15%. So it stays as edema also. So that's another factor why you end up in edema. If you have edema, you will have tissue necrosis because there's no oxygen delivered because it's stagnant and waste is left to the area instead of being reabsorbed. In the lungs, there will be suffocation because there's fluid and therefore exchange, the alveolus itself will be affected. Therefore, there's less perfusion or there's less exchange of oxygen. Cerebral edema can also happen, and headaches, nausea, and vomiting can occur, seizures, and even coma. The pressure on the brain itself will cause all these things to happen. Severe edema or circulatory shock then ends up in fluid being in tissue spaces. The pressure in the blood will be low. Blood will be low because the fluid is in the tissue, not in the blood vessel. This can decrease the pressure and may eventually lead into circulatory shock. All right, now let's see how the venous blood is returned back to the heart. Blood pressure is very important in the venous system, although it's not as strong as in the arterial system. Like we said, blood from the head drains down to the superior vena cava, so that's a big help. And then you also have your contraction of your muscles, therefore squeezing the blood vessels, especially the medium-sized veins. And by doing this, like in this case, contraction of both muscles pushes the blood in this chamber to go up, and contraction of the next group of muscles helps it to go up further. By way of this, it's almost like moving anti-gravity. Time we breathe, muscles in the thoracic area squeeze blood vessels, and they end up being perfused, going up to the heart. Exercise also helps to increase venous return. There's faster heartbeat. Skeletal muscles are squeezing, also milking vessels. The heart is dilated and increase in flow in its coronary arteries. Respiratory system is increased, and therefore more thoracic pump happening. All these favors increase in perfusion. Venous pooling occurs with inactivity, especially if it is due to a long surgical procedure, especially if the patient is bedridden. That's why we put those trousers which pump the blood vessels, pump the muscles so the blood vessel can pump the heart. Jet pilots usually wear pressure suits, especially in long trip or long situations. If the pressure goes too low, you can end up in shock, and the cardiac output is insufficient to meet the body's metabolic needs. If it's because of a failing heart, then you call this cardiogenic shock, or MI. If it's low blood from the venous side, then we call it low venous return, or LVR. Low venous return can be because of low volume. When there's low volume in the circulatory system, then it may be because of loss of blood direct to trauma, burns, or dehydration. The venous system can also be obstructed by a tumor or some aneurysm or trauma. And the long periods of standing and sitting or widespread dilation can make the blood stay in the venous, which is our capacitance vessels. Pain, neurogenic in origin, right, can give a loss of vasomotor tone and lead to vasodilation and shock. Toxin from bacteria can induce septic shock, which leads to vasodilation. A second exposure to an allergen can start anaphylactic reaction, which can be fatal also, especially with all the chemicals and hormones that are released in anaphylactic shock. When the body is able to compensate, a person faints and falls to a horizontal position, then we call it compensated shock. When compensation is not enough, then we have to induce some other method, so we call it decompensated shock. There are several routes in the brain, and most of these are for better perfusion. Total blood flow to the brain about 700 cc or ml per minute. Any few seconds of deprivation can result in a loss of consciousness. 5 minutes or so can result in brain damage that's that will not return to normal. And whenever we need some areas for better perfusion, blood flow is directed to that spot or area. Brain regulates its own blood volume. Cerebral arteries dilate when the blood pressure drops, and we also control this chemical equation, which leads to either too much acidity or there's less acidity where alkalinity will dominate. If there's too much carbon dioxide, we call it hypercapnia, which then increases the oxygenation, right? Dilates also blood vessels. Hypocapnia raises pH, which then does the opposite, right? It stimulates vasoconstriction. When you hyperventilate, you'll end up losing a lot of carbon dioxide, and you will be more on the alkaline level. TIA, transient ischemic attacks, can also be because of momentarily loss of perfusion. The cerebral arteries may have gone into spasm. Hopefully, it's not too long because it can lead to impending stroke. CVA is cerebral vascular accident, not cardiovascular. This is your medical term for stroke. This could be due to atherosclerosis, building up of plaque in the blood vessels, clotting that went out of the big vessel, now going to the smaller vessels, and of course, ruptured aneurysm. Serious sequelae can happen: blindness, paralysis, loss of sensation, loss of speech is probably the most common. Strokes or CBA really can be sudden, especially if the pressures have built up through the years, and also the quality of tissue is becoming less protective and can lead to stroke. Skeletal muscle will have blood flow depending on how much is available and how much the body needs it. Exercise again increases flow to the skeletal muscles, and every muscular contraction helps the valves to bring back blood. The lungs, on the other hand, will have low pulmonary blood pressure. The flow is slower, more time for gas exchange, which is also good. It also prevent fluid accumulating and pulmonary capillaries absorbing fluid. It will actually help it. This time it will help it because you will end up not leaving water behind. Unique response to hypoxia, low oxygen. Pulmonaries will constrict in areas that are decreased, but it will redirect flow to better areas where you have better ventilation, which is the lungs. Here's a picture of the pulmonary circuit where you will see the heart delivering blood to the pulmonary artery. And again, because the heart is pushing blood to an organ like the lungs, it will approach it to its pulmonary artery. But keep note, this is deoxygenated blood we just collected. So that's why the pulmonary artery will carry in it deoxygenated blood. Once the blood has been rid of carbon dioxide and oxygen has perfused the area or has diffused into through the alveolus, then oxygen will be high in the exiting vessel, which is the pulmonary vein. It will then deliver it to the right atrium, to the left atrium, down the left AV valve, and into the left atrium, and down into the left ventricle. Once in the left ventricle, it will now be pushing oxygenated blood through the aorta. Okay. All right. Then, because of that, you will have more blood perfusion in that area, and especially in the systemic circuit. All right. We'll take a quick break from here, and then we will continue on with the blood vessels.